Good morning, everyone, and welcome to MonteHeart today. We have a change of topic for today, and we will discuss about conduction abnormalities after transcatheter tricuspid valve intervention. We will see what are the clinical implications and the therapeutic options. This is a topic we were asked to present at the last TCT a few months ago, and I will show you the slides and the results of this study that we conducted. So let's start with some anatomy and to understand why this is particularly important in transcatheter tricuspid valve intervention and even surgical interventions. As you all know from our lessons in anatomy at med school, the atrioventricular node is very close to the tricuspid valve. As you can see here, this is the portion where the compact AV node is, and then the penetrating branches from the atrioventricular nodes, they are very close to the tricuspid valve before bifurcating into the left and the right bundle branch. So this proximity between the atrioventricular nodes and the tricuspid valve makes all the interventions on this valve at very high risk of heart block or in general conduction abnormalities. And as you can see here, and this is particularly relevant for all the procedures that we will be discussing today, the atrioventricular node is, of course, on the septal portion of the valve, so close to the septal leaflet, closer to the anterior leaflet, so in the anteroseptal position of compared if we are looking at the tricuspid valve from above. So this is just a background slide to see what we know about surgery and what is the risk of conduction abnormalities necessitating permanent pacemaker implantation after tricuspid valve surgery. In order to compare this with transcatheter intervention, here we are discussing only isolated tricuspid valve procedures. So combined mitral and tricuspid or aortic and tricuspid are not discussed here. So if we look on the left, that's the latest analysis from the STS registry on patient undergoing isolated tricuspid valve repair. And based on this registry, the risk of necessitating a permanent pacemaker at 30 days is 6%. As you can see, at the bottom, however, the total of procedures, in particular, if you look at repair in blue, is more or less stable. There is a huge increase in replacement. And we know that replacement, as you can see on this forest plot, is at much higher risk of permanent pacemaker compared to repair. If we look at the right, this is a meta-analysis we performed on all the studies on isolated surgery, either with bioprosthetic or mechanical valves. And as you can see here, we focus at the 30-day rate of permanent pacemaker. This is 10%. So this is important because this is our benchmark when we are considering transcatheter studies. Also, what we have to acknowledge is that are very selected patients, usually in their 60s with very low comorbidities in order to undergo isolated tricuspid surgery. And this is the entire landscape of transcatheter procedures and devices. Starting from the top, we have orthotopic replacement. We have coaptation enhancement devices like edge-to-edge repair, heterotopic replacement, when the replacement is performed not on the tricuspid valve, but for example in the inferior and superior vena cava, all the spacers, and annuloplasty device. So we will be discussing most of them today and see what's the risk of conduction abnormalities after transcatheter intervention. So starting with edge-to-edge repair, the need for permanent pacemaker is, of course, very low. By definition, here we are grasping the leaflets. As you can see here, the clip is very far from the annulus, so there is theoretically no risk of conduction abnormalities. On the top, this is the triluminate randomized trial, where tear on the tricuspid valve is compared to, in a randomized fashion, to medical therapy. And the risk of permanent pacemaker was 2.9%, the same between treatment group and medical therapy. If we look at BRIGHT, which is a post-market registry, real-world registry, with the exploring tricuspid tear, there was no pacemaker at 30 days. So then we go to the annuloplasty devices. This is another procedure which is basically reproducing the surgical annuloplasty. As you can see here, the ring is designed not to be complete and to spare the portion where the atrioventricular node is penetrating the membranous septum to minimize such risk of heart block. And here you can see some studies which indeed they show a very low risk of necessitating a permanent pacemaker, 3.8% in tri-repair, tri-band. Out of 52 patients without baseline pacemaker, only one necessitated one within 30 days. And the early feasibility study done in the United States with the CardioBand device, which is the one you see here in the figure, no patients out of the 26 without a pacemaker had necessitated a permanent pacemaker at 30 days. So here we mentioned, just for completeness, heterotopic transcatheter replacement. Even in this case, the risk of having a pacemaker is theoretically zero. We're very far from the tricuspid annulus, so only one patient had the permanent pacemaker in the Tricus Euro out of 27, most likely for other reasons rather than interacting with the atrioventricular nodes. And here we come to the orthotopic transcatheter tricuspid valve replacement, which is definitely a hot topic. It's a procedure that is being investigated in multiple studies. We have one randomized trial published so far, which is the TRISCEND-2, the one on the right. It was published and presented during the last TCT. And you can see other devices here on the left, the CardioValve system, the Lux valve, the one in the middle. And let's see which numbers we have so far based on published data. So on the left, we have a 10% for CardioValve. 5.7 is what was reported for the Lux valve. There are several studies from China and from Europe. In any case, the rate of pacemaker is single digit. On the contrary, for the Evoque, this was the initial cohort of TRISCEND, and this is TRISCEND-2. I can tell you now we have the published data from TRISCEND-2, the randomized trial, and this figure is between 25 and 29%. So 1 every 3 patients necessitated, 3 or 4 patients necessitated a permanent pacemaker within 30 days. So the clinical implications are very obvious. This is a patient that experienced a complete heart block 3 days after transcatheter tricuspid valve replacement. So this is why it's very important to investigate and understand why this is occurring and what we can do to minimize such risk or to have some backup therapy for these patients. So this is why we initiated this registry, the TriPlace registry. This is a global multi-center registry on transcatheter tricuspid valve replacement. It's investigator-initiated. It was initiated together with Dr. Latif here in Montefiore, Rishi Puri from Cleveland Clinic, from Neil Pham from St. Michael's, and Thomas Modine from Bordeaux. And we invited all the co-investigators you see here below, plus many others that joined later. It's a retrospective, single-arm, and open-label study. We are investigating all the procedures on orthotopic TTVR. And we excluded at the beginning all the patients being in studies, so we didn't disclose for the first study any name or size of the valve, with the goal of examining the safety and the efficacy of transcatheter tricuspid valve replacement. So these are the first results. I'll be very short and show you the main findings. So we will start seeing which is the incidence and the timing of such conduction disturbances. So if we look at the left, that was the initial population, the first analysis. Out of 263 implants, 75 patients were excluded because they had a baseline pacemaker, so there was no interest in analyzing this, as well as 3 patients who required a surgical conversion. So our total cohort was 185 patients. Of these patients, 20.6%, they were found to have a new right bundle branch block after the procedure. On day 1, this is the EKG on day 1 after TTVR, and 13.5% have a high-grade atrioventricular block, which basically is a type 3 completer block, or type 2 with an indication to permanent pacemaker. On the right, you can see the timing of such conduction disturbances. These are all the high-grade heavy blocks occurred within the first month after TTVR. As you can see, most of them occurred in the first week after TTVR, 88%, with other 3 events recorded later, up to 34 days. So clearly, the period where most of these conduction disturbances can occur is the first week. So then we investigated which are the predictors of conduction disturbances. A baseline left bundle branch block or left anterior or posterior fascicular block was found to be associated, regardless of age and device oversizing, with the occurrence of high-grade heavy block. This can be seen also, so this risk was almost 4 times higher in patients with baseline left side conduction disturbance. And if we look at, on the contrary, if we look at all those patients having a baseline left bundle branch block or left anterior or posterior fascicular block, 1/3 of them, 32%, they experienced a high-grade heavy block after TTVR. So this is clearly an important risk factor in our patients undergoing TTVR. The management here, this is just a report from this registry, how these patients were managed. Again, this is considering compassionate use cases, all the early experiences, as well as commercial cases. So there are many different management strategies. The most common was with leadless pacemakers, 45.5%. Some patients also required a dual chamber pacemaker, while for others, the investigators prefer to implant a coronary sinus lead. And here we arrive to the conclusion. Conduction disturbances after TTVR, they occur in, on average, 14% of patients at 30 days after TTVR. And this is for high-grade heavy block and considering all the valves. Of course, there might be some differences per each specific valve, and as soon as we will have more data, more granular data on this, we'll be glad to analyze these other findings as well. Most of these high-grade atrioventricular blocks, almost 90%, occurred within 1 week after TTVR. The higher predictor of high-grade heavy block was a baseline left bundle branch block or left anterior posterior fascicular block. And very limited data exists in patients with undergoing TTVR with pre-existing right ventricular leads, like in dual chamber pacemakers. So it's very important for the future to perform dedicated risk assessment in these patients, doing this procedure already with a backup pacing strategy, such as a leadless pacemaker, ideally with the use of TE, because we have a newly implanted valve on the tricuspid valve, and clearly we don't want to embolize or migrate this valve. After transcatheter tricuspid valve replacement, it's also very important to monitor these patients for at least 2 weeks, ideally 1 month. We see that the period in which most of these high-grade heavy block occur is the first week. So at least 2 weeks is needed, but since this therapy is in its early stages, I think it's safer to continue monitoring them up to 1 month. Okay, this was the presentation, so please write in the chat if you have any questions about this. Millie, can you promote Dr. Mignatti and Dr. Safin? All the others are co-guests.
Yes, hold on.
I might have a question. I'm gonna talk here because thanks for the presentation. Very interesting and insightful. So because there's delays in the occurrence of AV block, how long do you keep them in the hospital? Is it better to keep them more like 2, 3, 4 days, or you just send them home with the monitor, or how do you do that?
Thanks. This is really a great question, Louis, and thanks for asking this. So basically, our experience is, again, now that we know a little bit more about these patients undergoing TTVR, we see what is their baseline risk. So if they have no conduction disturbances, and also based on the valve that we are implanting, of course, we monitor them with telemetry in the hospital. Usually they go for, let's say, they stay for sure for the first 2-3 days in the hospital. If everything went well and we have no issues, we can discharge them as long as we have no changes on the EKG with the monitor, with the Zio patch, which is not available everywhere. I know in Europe this is not possible, so they might keep patients longer. But for us, having this device is very safe because we can rely on this live monitoring from the Zio patch. It's something that we do also for our TAVR patients. For the TAVR patients, we do it only if there is an increased risk of conduction abnormalities. On these tricuspid patients, we do it on all of them because the therapy is very at its early stages, so we feel safer in discharging all our patients with the monitoring device. I see we have also another question here from Dr. Mignatti. If there are any CT findings predicting the need for permanent pacemaker. So far there is no dedicated analysis based on CT. What I can say is that we have something that we can discuss about CT findings. More than CT findings, I was very interested because it's what we experience in TAVR. We know that the more we oversize the valve compared to the annulus, which means the larger the valve compared to the annulus that we are treating, the higher the risk of pacemaker. And this is what we see in TAVR when we are doing transcatheter aortic valve replacement. So we were very curious to know if this was the same on the tricuspid space. So far, we don't have definitive conclusions because, again, this is the only registry examining this outcome. But so far, we didn't find any association. So this means that we analyzed all the patients undergoing TTVR, and the oversizing based on both the unsystolic and the end-diastolic phase of the cardiac cycle on the CT was not associated with any increased risk of permanent pacemaker. So what this means, this is very important to understand because we have different valves and not all of them, they are implanted in the same way. Some of them, we saw this on the slides, they implant because they have some anchors. Others rely from the ventricular side, and then they have some radial force. Others, they are implanted just with radial force on the tricuspid annulus. Other valves, they are implanted because they have a different type of anchors, like the Lux valve, like this septal portion of the valve that is screwed to the vent, to the septum. So probably the design of the valve might play a critical role in the need for permanent pacemakers. We have other questions here. Let's start with the one from Manaf Safin. He's asking if we have any data on the clinical outcomes, mortality, heart failure hospitalization, or quality of life of the patients who develop conduction disturbances after TVR compared to those who do not, either in the registry data or the TRISCEND trials. So let's start answering this, and then we have another question. So far, we don't have any dedicated analysis on conduction disturbances. I'm sure this will come from the TRISCEND trial, and I can tell you what we saw in this registry. So in this registry, if you noted, I didn't use the word and the outcome permanent pacemaker, but high-grade heavy block. And this was on purpose because some patients probably couldn't receive the permanent pacemaker because the high-grade heavy block maybe had a bad outcome. And this is what we saw in some of these patients. We had at least 2 patients in some centers who participated in the registry who couldn't receive a permanent pacemaker. But this doesn't mean that the rate of high-grade heavy block is any lower. So far, these two patients had a very prolonged, complicated hospitalization. So clearly, having a high-grade heavy block might be associated with worse outcomes, especially if this is not recognized. And out of all the patients analyzed in this registry, there was also one that was discharged, was not on a cardiac monitoring device, and the patient died because of high-grade heavy block. So this is clearly a very relevant complication, and all of us, we should be aware of and give these monitors to our patients to minimize such risk of conduction disturbances and potential bad outcomes if not detected timely. But for sure, as long as whenever we will have more data, more granular data, we will investigate if the outcomes will be any different in patients having this outcome and those who do not have this outcome. Let's go to we have another question from Pier Pasquale Leone from our team. Do you think a TTVR, which means a transcatheter tricuspid valve repair first approach, arguably safer, should be the first line for patients with TR, unless not candidate due to extreme anatomic reasons requiring them to undergo TTVR? This is a very, very, very important question, and it's probably difficult to answer. Every center, every physician has probably a different approach to this. We know that repair is, by definition, a very safe approach. The complications with the repair strategy, which means edge-to-edge repair, is with edge-to-edge repair, like the TriClip, for example, which is the only commercial device so far available, is very safe. Complications are minimal if we talk about mortality and also conduction disturbances. Whether clearly, if the patient is not a repair candidate, we have to explore the replacement strategy. However, for those who fit both criteria to be treated with a repair or a replacement approach, both of them, so both options are viable. So what we should decide for our patients, that's a difficult question. I think it has to be tailored on the patient and especially on the echocardiographic findings, because we know that repair is safe, but also the outcome and the result of the procedure is highly variable. It's very difficult to predict. And also, we are not even sure how persistent this is. We see in our practice that in some patients we can get an optimal result, but when we compare, even if we have no direct comparison so far, if we compare a repair study with a replacement study, when we repair a tricuspid valve, we can definitely reduce the TR, but we might still have moderate or severe. So yes, going from massive, which is the most severe grade of tricuspid regurgitation, to moderate or severe, of course, is very important and is highly significant for our patients. But if we consider a replacement strategy, the tricuspid regurgitation is completely eliminated. So it's rare for us to see more like mild or more tricuspid regurgitation after replacement. So this is something that we have to consider when we are choosing our strategy, which is the outcome that we want. Also, what we have to consider is that with replacement, the patient has to be on anticoagulant therapy. But this is not a great problem if we when we treat patients with tricuspid regurgitation, because based on all the registry and the studies, we know that 80-90% of patients with TR, they already have atrial fibrillation, so they already have other indications to anticoagulation. So they will be on anticoagulant therapy regardless of the tricuspid valve. But this is also something else which is important to acknowledge when we have to decide between a repair or a replacement strategy. So are there any other questions in the chat? Taylor, Wasla, do you have any questions?
Can I ask another one?
Of course.
And sorry if you mentioned it already, but is there data on those patients who develop a high grade or completely heart block? Is there data on the recovery of this heart block? Like, what's the proportion of these patients that long term will not have a heart block? Because you see this sometimes with TAVR, they have transient heart block in the hospital and then they recover and then they're okay and they never use their pacemaker ever again. Do you have that type of data for?
Excellent question. The short answer is no. We don't have this data yet. We have very few patients, but this is what we will be investigating. There are some studies already investigating patients not only receiving a new permanent pacemaker, but also patients with existing pacemaker if the pacing rate changes after the implantation. We know on the aortic side, when we do TAVR, that on average, 50% of patients requiring a pacemaker, they won't need pacing at all after 1 month or at 1 year. How this rate is on the tricuspid, I think it's early to know. We need more patients. And also if there is an impact on patients with an already, with a pre-existing lead, because we are basically, in most of the cases, gelling this lead with the new valve. So this is another important topic that we have to understand in those patients if we are interfering with the function of the lead, and which is the rate of this interference, and this is significant. So far, I know for sure that there is a sub-study being performed from one of the registries, and with one of the valves, it seems to be safe, one of the valves being used for TTVR, but we need this to be published and see more patients before having definitive answers to this question. Thank you. I have another questions here from the chat. Taylor Remillard is asking, was there anything unique about those who developed high-grade heavy block after 1 week? And was the technical procedural success of TTVR in those with pre-existing RB leads versus those who do not? So let's start by answering the first question. Anything unique about those who developed high-grade heavy block after 1 week? I will say no. Those patients had the risk factors that we saw, especially those patients had the left bundle branch block at baseline, which conferred them a higher risk of high-grade heavy block after TTVR. Other than this, there were no specific risk factors, or at least no risk factors that we found in this analysis. But again, we need more data and potentially maybe we might find something else. Even if sometimes we see this also in TAVR, there are patients who develop the heart block later. So it's very important to know the timing and for how long we have to monitor these patients. That's why it's probably early to say who is gonna have a complete heart block within 1 week, 2 weeks, or 1 month. So that's why I recommended to monitor all of them up to 1 month after TTVR. So the other question was the technical procedural success of TTVR in those with pre-existing RB leads versus those who do not? So we have only one randomized trial that has been published on this field, that is TRISCEND-2. And we have some registries, in particular from the TRISCEND-2 is on the EVOC valve, and then we have a registry from which is investigator-initiated, like the one I presented you, on the LUX valve. So far, there is no direct analysis on patients with and without RV leads. Having a pre-existing RV lead was not an exclusion criterion, and so far doesn't seem to be associated with worse outcomes. Of course, we have to acknowledge that all these patients are highly selected. This is a randomized trial with an eligibility committee. Every CT, every echo is screened to see if the lead, how slack there is on the lead, if it's an ICD or just a pacing lead, because it's different. And so there are many analyses being performed to avoid those high-risk cases. So I think as long as we will have more, as soon as we will have more commercial cases, more cases, more like different cases than those highly selected in the trial, these questions will probably be answered in a better way. So far, we didn't see a signal for an increased risk on those patients. But again, we have to be very cautious in who are the patients receiving TTVR. There is a sub-study in which we are participating in one of these registries in which these patients are being compared. Even if from a statistical point of view, we didn't see any significant difference, I have to say there might be an increased risk. We have to see if this is, and I don't have the answer for that, but we have to see if this is related to the valve and how where the lead is positioned compared to the tricuspid valve, if it's in a commissure, in which commissure, which kind of pacing lead we have, or ICD lead. I think this is also a very large topic that we have to explore. As of now, when we are treating these patients, we are doing a very meticulous study, most importantly on the CT. And we do basically on the right ventricle, we do a spin of the ventricle on the CT to see the trajectory of the lead, where the lead is positioned, how much slack there is on the lead, and we try to predict the implantation to see if this can interfere on impact on the transvalvular lead that we have already at baseline. Okay, I see we have a lot of questions today. We have another question coming from Weiler. The other hospital, our fellows are asking, prior and after procedure, do you stop beta blockers or amiodarone if patient is chronically on these medications? The answer is no, unless we see, of course, high risk of conduction disturbances, any change in the EKG during the procedure. This is not what we've been doing. Usually we restart all the medications. Of course, we have to tailor this per every patient. If we see any change during the procedure in the EKG, if we know that they are high risk of high-grade AV block, left bundle, and if on telemetry, after the first night in the hospital, we see that there is any change in their electrical activity, then we hold the beta blocker. Yes, otherwise, if we have no conduction disturbances, we have no reason to stop them. So this is not what we are doing. Okay. I think we had a lot of questions, very interesting. I think we answered all of them. So I think we can conclude this MonteHeart today. We conclude a little bit earlier. Thanks everyone for joining. And we will have the other topic, which is also very interesting, as soon as our guest will be available at an emergency and he couldn't join us today. But thanks for joining. I think we had a lot we have a lot of very interesting questions, and definitely we can discuss about this topic again in the future as soon as we will have more data and more patients treated.